Thank you for having me here today. I'm going to talk to you about what we know about HNRNPH2 from the Simons Searchlight study. So I'll start out with a little bit of explanation for genetics to help you understand your genetic test report for your child. And in thinking about this, we have a lot of genetic information in our cells. It's actually about 3 billion alphabet letters. And this genetic information comes half from the mother and half from the father. One thing that's important to understand and a little bit confusing is that for almost all families with HNRNPH2, although the condition is genetic, in most cases it was not inherited, and that's important to know. So what I'm showing you here is a picture of a mom and dad and their two children, and what I'm trying to show you for this individual here is that there can be new genetic changes that are not inherited from either the father or the mother, but that start new in the child. And as I said, this is almost always the case for HNRNPH2. This has important implications in terms of knowing just where it came from, and then also, as I'll explain, implications in terms of whether or not it will happen again. And for the most part, it will not. So let me try and put this in context. When we think of our genetic information, that 3 billion letters is housed in books like a set of encyclopedias called chromosomes, total of 46 of those. The difference that we're talking about is very, very subtle. It's just one letter. So it's not even as big as a single book that's missing. When we look at the individual letters, it's as if they're instructions and they make pages within that encyclopedia. And it's not even as if it's a difference in a page or a difference in a paragraph. It's literally as subtle as one single letter change. So I've highlighted in red a letter here, and it's that subtle. It's that small a change, but they can have that big an effect. Now the test, oops, I'm sorry. Pardon me, I hit the wrong button here. The test that many people had to be able to make this diagnosis was called exome sequencing. Now, what that is it's a shortcut to sequencing the 3 billion alphabet letters. So this is a representation of your genome or all the genetic information. And the way it's organized is that there are small bits that are embedded within a large amount of information that for the most part, either we don't understand or it probably has less significant impact in terms of changes. Because of that, many people do a shortcut, which is to sequence only what we call the coding regions of the genome, or that portion of the genetic information that is directly made into proteins or gene products. And so I've highlighted those regions here. So for most people, they did have a comprehensive look at all the genetic information, but only about the 1.5 or 2% of these gold nuggets listed here. And when that information was read out, it identified a change in HNRNPH2. Again, many individuals had this test by looking at the mother, the father, and the child to identify de novo or new genetic changes. And that oftentimes is what helps to identify those HNRNPH2 changes. So many families ask the next obvious question of this change occurred. Was there something that caused this? Why did this happen? Why should it have happened to our family? So in looking at this, we don't have information from the genetic testing about where or when this happened. So I can't say whether or not this happened in the egg or the sperm as an example, or if it happened shortly after conception, after the egg and the sperm got together. We can't tell that from that genetic test. But importantly, because this is a new genetic event, for most families, this will not happen again. So if the question is planning on having another child, for those two parents, there is about a 1% chance that it would happen again in a future pregnancy. But of course, that 1% is, at least in my mind, not a very high percentage and certainly not a reason not to have future children. Some people worry about recurrence for other family members. So parents may worry about brothers or sisters in their family, their brothers or sisters, or they may worry about their other children. For those other individuals in the family who have not had a child with HNRNPH2, the chance for them is basically infinitesimally small. It's not likely to happen. Um, One of the things that sometimes parents are concerned about is why should this have happened to us? And this is something that I can reassure you, this is not something a mother or a father did or didn't do that could have prevented this problem. All of our children, for those of us who have kids, have new genetic changes. In fact, I can tell you my sons have between 100 and 150 new genetic changes that their father and I did not pass on to them. So having new genetic changes is not unique. What happened in your family's case is that this happened to fall within the HNRNPH2 gene. Then there's no sort of reason that it should have fallen there, but it just was by chance it happened to fall there. So again, especially for the moms out there, there was nothing that you did that you could have done to prevent this, and nothing you did that caused this. So I'm going to switch over to what Simons Searchlight is. Many of you have been participants in this, and I'll show you the data that we have so far, and we thank you for that. And I'll try and explain what it is that we're doing and why it is that we do it. So in Simons Searchlight, we study many different neurogenetic conditions. So what I mean by that are genetic conditions that affect the brain. And we are a nonprofit foundation, part of the Simons Foundation. So as we do this, this is not associated with any company. And as our mission in terms of doing this is to be able to help move the science forward as quickly as possible. As we do this, we collect information from several different genetic groups around the world. It's an international study. And as we do this, we de-identify the information so no one knows who an individual is who's participating in this study, and we try and share it with as many qualified researchers as possible. So the researchers who do this are around the world. It enables you to be able to essentially share information with many, many people all at once, and not to have to answer the same questions over and over again. As we do this, we hope that this makes it easier for more individuals to study the condition and hopefully to make progress so that we can learn more and hopefully come up with treatments. As we're doing this, we also share this information back with families so that they and their doctors can learn more about this. And all of what I'm showing you today will be available to all of the families and any of your providers, any of your doctors or therapists, so that they can use the information to take care of your family. As we've been doing this, I'm very proud to say that it's almost 10 years that we've been doing this. So we've been doing this for quite a while, and we're not going anywhere. That is, we continue to do this, and we're committed to doing this for the long term. One of the nice things about the Simons Foundation is that this is all supported by funds from the foundation and doesn't require NIH funding or government funding or fundraising for this. So I can say this with great confidence that we're going to be around for a very long time. As we do this, we try and make it easy for families to participate from wherever they are around the world. And one of the things I'm proud to say that we've started doing is increasing the number of languages in which we're communicating and enabling families to participate, because as a global community, and especially as a rare disease, everyone matters. It's very, very important that we try and learn as quickly as we can with people wherever they are. As we do this by first making sure that this is the right diagnosis. So that's why we ask you to review that genetic test report. In rare circumstances, we found that someone thought this was the genetic diagnosis, but in fact, that was incorrect. So we want to first make sure that you're getting the right information. So we start that first. And then we collect information both by telephone interview, which gives you the opportunity to talk with one of my genetic counselors who's quite familiar with NPH2. It also allows us to make sure that we get the right information, and when we need to be able to clarify that by looking at medical records to be sure the information is accurate. We also do something called a measure of adaptive behavior. This is called the Vineland Adaptive Behavioral Scale, and allows us to see how your child is progressing developmentally. And that's a standardized scale so that we can compare children around the world and also be able to evaluate how they're doing by their age. In addition to that, there are certain conditions that may be specific, like seizures, which I'll get into a second, and it may help us to gather deeper data, more information about that. So we have some standardized questionnaires as well as standardized measures that we do this, and these we collect online to make it more convenient for families so they can do it wherever, whenever might be easiest for them. And again, all of these data are de-identified, but then shared very, very broadly with researchers around the world. So I'm going to now shift to tell you what data we have specifically in Simons Searchlight for HNRNPH2. And you're also going to hear from Dr. Bain about information that she's collected at Columbia. These are complementary. Some of her information is from in-person assessments. And again, Simons Searchlight hasn't done that. So she'll be showing you some information that's in some ways more detailed. As we started this, I want to give the community a sense of how things are going. And in particular, it may have been confusing as you registered, so I'd like to hopefully clarify some of these things. So we had 34 families register, that is to put in their information online about being part of this community. Of those, 23 of them submitted their laboratory reports to us to review. And so as you can see, that means that there are 11 people that didn't go from registration to lab review. That may have been because they decided they didn't want to participate. And of course, that's perfectly fine. But just to clarify, just because you register, you're not part of the study. You really, as you'll see, won't progress to be able to have your information as part of the study until we can review your genetic laboratory report and make sure that this is in fact the correct diagnosis. As you can see, 22 of the 23 individuals that we reviewed, this was the correct diagnosis, but as I said, very rarely, but occasionally we find that, in fact, that isn't the right condition, and that there may have been a result that was reported, but that's not really the diagnosis. Of those 22 individuals, 11 went on to do the medical history interview, which I'm going to describe the data from today. And as you'll recall, this condition is an X-linked condition. So for this condition, it's something that predominantly affects females. And so that's the reason why we have 16 females and 2 males only with this condition. Just as a reminder, females have 2 X chromosomes, and males have only 1 X chromosome. For this particular condition, it's something that we see on only one of the 2 X chromosomes in females. So 1 X chromosome is fine, and the other X chromosome has one of these changes. One of the reasons we think we don't see as many males is because females have that second X chromosome or a backup, so that if the 1 X chromosome has a change, the other one is fine, and that other one in some of the cells can take care of business. Males, because they only have 1 X chromosome, don't have that backup, and we think that in some cases not having that backup can lead to a very, very serious problem. And so some of those males may not actually make it to be born, and that's probably the reason why we see so many females and a preponderance of females with this condition. One of the limitations that you'll hear me talk about is that the age of our participants ranges from 2 to 39, but almost all of the individuals are still under the age of 20. And so some of our limitations are that long term, it's hard for me to know what this might be for individuals when they're in their 30s or 40s or 50s, because we simply don't know from individuals out there. That's not to say that individuals aren't out there who have this diagnosis, who are in their 30s and 40s and 50s, but in many cases they aren't getting genetic testing with doctors, and so they don't know they have this condition. And if there were one gap I would hope we could fill soon, it would be that gap, because it's the information that we need to understand long-term the prognosis for your children and to be able to know how to plan and hopefully how to prevent some of the things that we might be seeing in adults. So I'm going to review the genetic changes that we see in the community, and I know this is a little bit hard to understand sometimes, but this will help in terms of reading your genetic test report. So what I've shown you is that all of the changes that we see in this gene are what we call missense changes, and let me explain what that means. This number that you see in the middle here is the numbering of some of the amino acids or the building blocks for the HNRNPH2 protein. So for some of you, the change is at position 114, amino acid 114. For some individuals, it's amino acid 206 or 209 or 210 or 212. On the left is the usual amino acid that we have at that position, and on the right is the substituted or the new amino acid that the individual has. In parentheses, I've shown you here how many individuals have this particular change, and if I didn't have a parentheses, it's because there's only one person. What you can see from the distribution here is that it's not random. The changes across the gene are not random in their location, but in fact, you'll see that they're at position 206. There are two different types of changes that we see here that account for 17 of those 22 individuals. So amino acid 206 is a very, very important spot within the protein. Then when you listen to some of the other talks, you'll understand and you'll be hearing more about this. There are other positions that are probably especially important. So we think 114 may be especially important. And again, if you look in terms of space, these all tend to be very close together. So close between amino acid 206 and 212. So this is telling us something about the function of the protein and probably effects on function because of a very, very important region of that protein. And again, even though individuals with, for instance, this specific change might be the same, they're not related. So it's not necessarily that your families are all related way, way back, because again, recall that these are new genetic changes, not things that are inherited. So let me review now the specific medical information that I discussed. Predominantly, the good news is that this is something that I think for most of you, what you've been observing is what the condition is. That is that I don't think you're going to have many surprises, but I'm going to summarize the things that we've seen again across these 18 individuals. Predominantly, the condition is one that affects the brain. So it can manifest in slightly different ways. To a certain extent, I think these differences are due to the fact that the individuals are different ages, and some of them are young, some of them are older, and certain manifestations may take some time or may change with the phase of life. Almost everyone has problems in terms of delays with their when they learn to do things. So whether it's learning to walk or whether it's learning to communicate, but a universal part of this is problems in terms of what we think of as developmental milestones or when people learn how to do things. This won't be any surprise to you, but this can manifest in many different ways. Problems with language, for instance, and either being nonverbal or minimally verbal. Many individuals will have problems in terms of anxiety. I think that has to do with difficulties in terms of understanding the world around you and having it being very confusing, and so leading to anxiety as a result of that. And some individuals, about a quarter of individuals, also have a diagnosis of autism or autism spectrum disorder. Again, I think things are more similar than dissimilar across the community, but I think they can change by the age. And so things do may become more apparent or more obvious at different ages. In addition, some individuals have problems with vision. I think this is a very important thing to diagnose, and it's common enough that everyone should be seeing an ophthalmologist or an eye doctor if they haven't already. And the reason I say that is because for one to learn, it's very important that the information is coming into the brain correctly. That is, that the world around the person is accurately represented with vision, that you can see where you're going, that in terms of safety, you can see where there might be things that you would run into, and that to be able to understand and learn, you can correctly see the world. So some of the things that can be treated, for instance, are what we call crossed eyes or strabismus, or a lazy eye. That's something that may be corrected either by patching or sometimes surgically, and that's something that is fairly common. There can be other issues in terms of whether or not you can see at a distance, and again, this may be helped by spectacles or by glasses. But some things are a little bit more challenging. So one individual, for instance, had problems with the brain itself in receiving the images from the eye. So we call that cortical blindness. That's something that isn't fixed by glasses, but something that really is in the brain itself. So all of these things in vision are things that really need to be seen by a pediatric ophthalmologist, because children with neurodevelopmental disorders can't be able to report what they're seeing like others can. They can't read an eye chart, they can't report back what they're seeing, and so it takes someone who's really specialized who can work with children with special needs, but I do think that's important. In addition to that, there are many ways that this can manifest in terms of the neurological issues. These are fundamentally problems with the brain, but they manifest through different parts of the body. And so I say this because I don't want you to be surprised or alarmed. I don't think this will be surprising or alarming to anyone, but some of the girls and some of the boys, but mostly girls, can have a smaller head size. So when the pediatrician goes to measure the head circumference, that can be a bit smaller. Many of the individuals have problems with tone, and so this can either be that they're loose or floppy or hypotonic or low muscle tone. Occasionally, and I tend to see this later, they can have higher muscle tone to the point that some of them may have been diagnosed with cerebral palsy. But let me be clear, this is not typical cerebral palsy in the sense of not getting enough oxygen at birth, but this is really due to HNRNPH2. For many individuals, this can result in problems with being clumsy or not coordinated or taking longer in terms of learning movement. But this is something that does, individuals can learn to move. It just takes a lot more reinforcement, a lot more therapists, patients, and help to be able to learn those skills. One of the issues that thankfully is only present in a minority of individuals is seizures, but when it is there, is really important to recognize and to treat. And Dr. Bain is going to be speaking more about this. In terms of things to watch for, many of the individuals, 3/4 of the individuals, had grand mal seizures. So what we mean by that is that jerking movement, something where you can see the arm, the leg jerking. That's easier to be able to recognize. But a petit mal is something that can be harder to recognize. It may look like someone kind of zoned out or staring off into space, or just difficult to snap and bring back. If there's a question, my suggestion is to make sure that you see a neurologist and that they do an EEG, an electroencephalogram, where they put the electrodes on the head to be able to look at the brain waves. And that way you'll be able to know for sure. One of the other common symptoms are gastrointestinal or tummy problems. This is also actually related to the brain, although it might not be so obvious why that is. But with low muscle tone also comes low gut tone. So things don't oftentimes move as quickly through the intestine, or sometimes they move too quickly. And so what you'll see is a combination of constipation or diarrhea, or in some people, you'll actually see alternations between the two. Some days are constipating, some days are really loose. But within these, there's not, unfortunately, a magic bullet in terms of treating these, but there can be things that can be done in terms of medication, stool softeners, things that, enemas, or things to get things moving, as well as dietary interventions and exercise, and just physically moving the body is a good thing in terms of moving the intestines as well. For infections, my sense of things is that these are not any more common than they are for regular children. I say this in particular because I know people are worried about COVID and whether or not there might be any immune problems or immunodeficiencies, and everything we've seen so far suggests that there is not. Let me reinforce. There are not immunodeficiencies or particular susceptibilities. We do see some of the regular infections that we see in children. And I would say what I often hear is that the children may be, they feel like this is the child in the family who takes longer to recover, they're sicker longer, they're out of it longer, and they just, it hits them harder. But I'm not seeing evidence that they, for instance, are hospitalized with every infection, or that there's something that really is very serious and long lasting in terms of requiring being on a breathing machine or a ventilator or things like that. And again, although the numbers are small, We've actually looked throughout our neurogenetic conditions in Simons Searchlight, and we are not seeing evidence across the conditions that COVID is preferentially either infecting or putting kids in the hospital with COVID. So the numbers are small, but at least so far we're not seeing any reason for particular concern. Tied in with COVID and with infections are the lungs. So is there any specific problem with lung infections? And again, I put this in because I've been getting a lot of questions about COVID. What I would say is that we can see the usual sorts of things that we see in the community. Some people may get more than one cold, or they may even get a pneumonia, but I wouldn't say this is any more common than what I see with either other neurogenetic conditions or with, in general, just children in the community. Hyperventilation means breathing quickly, and my sense is that in some cases this is due to anxiety, that when individuals get nervous about things, they may breathe relatively quickly, but I don't think this is a fundamental lung problem where they can't breathe. In terms of heart issues, again, I would say this is reassuring. I'm not seeing significant problems with the heart. Again, we don't have people in their 50s or 60s, but so far the things that we do see are minor. A small hole in the heart, not that requires surgery, for instance, a heart murmur, or being able to hear the blood flow in the heart, but again, not requiring surgery. So to me, this is reassuring. We have had individuals who, and I think this is in part related to some of the gastrointestinal issues, but difficulty growing or gaining weight in particular. Many of our girls are on the skinnier side. Some of them are even short, so not just that they're not gaining weight, but they're not growing as much. And again, I think this is not something where I would necessarily go and start growth hormone or get extremely concerned about this, but I think this is largely issues in terms of intestinal issues and, being able to find the right diet and the right balance for things. One of the things that we should watch out for when the individuals or mostly girls get to be adolescents, when they go through their growth spurt because of the low tone issues, or in some cases high tone issues, we can see scoliosis or curvature of the spine. This is something easy for a pediatrician to monitor just on physical exam, just lifting up the shirt and looking at the back. And this is something that is important to be able to monitor. In some cases, there are things that can be done that don't require surgery. In some cases, there may be surgery that's required, but it is important because having a straight spine helps in terms of mobility, helps in terms of breathing, and long term, and I mean way long term into adulthood. Setting this up is for future health is important to keep the spine straight. Some other problems that we see, other orthopedic problems, are in particular related to the feet, and that has impact in terms of being able to stay walking or to stay moving around. So these are important things to address, and I know the families have been all over this. In terms of other manifestations, I don't see any severe skin problems. Many of the children actually have lustrous, beautiful hair, so it's not a problem. It's quite the opposite. But we do see some typical things, some rashes, allergies, eczema or dry skin. But again, I don't think it's anything in particular to be worried about. Parents have noticed some things that I think are absolutely correct, and I put them in another category, but they've noticed some things that are, I do think, somewhat specific. So they sometimes tell me that the girls will have high pain tolerance, that sometimes things that otherwise would have been bothersome to their other child, don't seem to cause problems, and I do think that's neurologically based. Sometimes people will tell me that there are problems in terms of the blood vessels. They get very flushed, or they may feel like they have something that we call Raynaud's, where the tips of their fingers may get very white or very red. That also is actually related to a brain problem, but the way the brain sends a message to what we call the autonomic nervous system to affect the blood vessels and how much they either dilate or constrict. I don't think this is immediately causing any problems or pain, but I do think is one of the manifestations we can see. In a similar way, not very often, but some have reported issues with temperature regulation, either running very hot, getting sweaty, getting red, and I think that's again related in part to what I mentioned with the vascular problems. In a good way, sleep has not been a major issue, but it occasionally is an issue, and dentition or teeth can be an issue, and seeing a pediatric surgeon, or rather a pediatric dentist for children with special needs, can be helpful for that. Just to give you a sense of how serious things are, I've shown you medications that individuals percentage of individuals who are taking medications for the condition. And I say this mainly because that gives you a sense of many parents wouldn't use medications unless they were pretty serious. But almost half of the children are taking something for their tummy, about a quarter for seizures, about 20% for behavioral or mood issues. And then one of the things that I also want to point out, although I'm not endorsing it, but simply reporting that we have had a couple families that have tried cannabidiol or medical marijuana. Again, I'm not endorsing this, but just simply to report that about 10% of the community has tried this. For the seizures, at this point, it's very small numbers. So let me underscore very, very small numbers. And I don't think we have enough data yet to be able to say what truly is most effective or what's working. I will say that seizures tend to be not overwhelming in terms of the majority of girls that have this. It does look like there are at least a couple different medications that have been working for the seizures. So this is not a terrible, terrible seizure disorder where nothing seems to control it. So I take that as a good sign. And then, as I said, there may be some of the new medications like medical marijuana or cannabidiol that may be helpful as well. So hopefully, if any of you have neurologists who are trying to work on your seizures, please share this information with them. So just as a summary, and I'll conclude here, the most common issues that we see are things that have to do with development and brain function. But I hope I've given you some things specifically to do if you're not already doing to take care of your child, making sure that we're taking care of vision issues, making sure that we are checking for seizures if there's any suggestion that there might be seizures, checking for scoliosis, and therapies are definitely helpful. So therapies in terms of being able to improve muscle tone, being diligent about repetition, and this is especially true to help with communication issues, and just generally in terms of being able to reinforce and help with potentially any autistic behavior or anxiety, behavioral therapists to help with that. I do want to reassure you that as far as we're saying, there are not, besides the seizures, I don't think any major medical problems. There may be small issues with growth, but they're not life-threatening by any means. And there's something certainly that the children are doing fine, even if they may be, either a little shorter or a little bit skinnier. They're still healthy otherwise. So with this, one of the things that I also wanted to share just very briefly in case there are any investigators is that, again, we are trying to make sure that this information is used responsibly in a de-identified way, but that it's very, very widely accessible. And so if there are any researchers, please do go to SFARI Base. If you have any questions, there's an email there that you can send to what we call collections at SFARI Base, and they'll be happy to help you understand the process and make sure that it works efficiently for you. So I thank you for your time and looking forward to the rest of the meeting.